evaluation form for each of our speakers. Dr. Kayla?
Hey everyone, I'm pretty excited to talk to y'all about hemophilia and the factors used to replace those what's missing in hemophilia patients. While I was on my peds and monk rotation, I had one hemophilia patient, so I'm not an expert, but we did have that same patient for about 3 weeks. So we got to revisit the subject pretty often. So I just want to share with y'all the things that I learned. So I'll start off with just an overview of the disease state. It's a congenital bleeding disorder that is X-linked, so it's almost exclusively seen in the male population. It's due to a deficiency or absence of a coagulation cascade protein. And then in hemophilia A, this is known as classic hemophilia. Okay. Can y'all hear me? Okay. So hemophilia A, which is also known as classic hemophilia, that's when you have a deficiency in factor VIII. And this is the most common type of hemophilia. It accounts for about 80% of the cases. And you'll see it in about 1 out of 5,000 male births. With hemophilia B, this is also known as Christmas disease. It's the factor IX deficiency. You'll see it in about 1 out of 30,000 male births. And it accounts for about 20% of the total cases. So once you decide what factor is deficient, you can determine the severity of the deficiency. And so a mild deficiency is considered when you have greater than 5% of factor level activity. So these patients are still going to bleed more easily, but it's going to require some kind of trauma or surgery before they have a hemorrhage. And then with moderate disease, between 1 and 5%. And then severe disease, you'll have less than 1% factor level activity. And then these patients are more worried about spontaneous bleeding, bleeding into the joints, the muscles, internal organs. So let's talk about therapies. It's come a long way over the years. Back before 1950, all you really could do was transfuse a patient that could live to be about 30. Then we discovered cryoprecipitate, moved on to plasma products, which worked well for us up until about the 80s when HIV was discovered to be a bloodborne illness. So you had about 50% of hemophiliacs seroconverting to having HIV and then ultimately dying of AIDS. So at that point, started looking at different options like recombinant products, and better purification processes. And so with recombinant, this is some of the things that really differentiates our product, is whether they're recombinant, how they're manufactured, so you can either get from pooled plasma or you can use recombinant DNA technology. And then furthermore, you look at purification techniques, so you have affinity chromatography, heat treatment, and solvent detergent treatment. And then you can also look at recombinant specifically, and they have a first, second, and third generation, and they just get more pure with each generation because a first generation is going to have albumin as a stabilizer in it still. Second generations, they use albumin during the manufacturing process, which removes from the final product. Then third gen is free of albumin altogether. So how do we dose these medications? You can either do it prophylactically or episodically. So it's prophylactic therapy. You're administering it on a schedule. It can be once or twice a week. It can be every other day. It kind of depends on the patient's needs. But they're seeing that this may have long-term benefits, especially started early in life in some of the severe hemophiliac patients. They're seeing decreased joint problems because it's preventing hemarthrosis, so you're not having as much bone and joint destruction. And then versus episodic therapy, which is when you only administer it in response to an active bleed. And so dosing in this situation is going to depend on severity and then the location of injury. So underneath, I have a chart that shows the hemorrhagic site and then the corresponding desired hemostatic factor level. So like for joints, you're going to aim for increasing their factor level to 50 or 70%. And then in order to determine how much factor you're actually going to use to make these increases, I've included some calculations down below. So it's different for each factor. Factor VIII is kind of consistent throughout their products. Administration of 1 international unit per kilogram should increase your plasma factor level by about 2%. So you can calculate by taking your desired level, subtracting your baseline level, and then multiplying it by half the weight. For factor IX, it's similar. You're going to, for every 1 international unit administered, it should raise your level by 1%. So the calculation in this situation is desired level minus baseline times the full weight. But in this situation, there's an extra variable, and it's called the reciprocal observed recovery. And I think you can technically calculate this yourself, but they provide typical F factors to use, and it ranges from 1 to 1.4. Find it in the package inserts, and it's also on the chart on the back of your page. I included it with those products that require it. So after you infuse the factor, you can check about 15 minutes later to see if you've achieved your desired factor level. And if you're far off from what you expected, it's at this point that you might want to start considering complications. And the main complication with factor therapy is inhibitors. So inhibitors are just basically an antibody that is formed against your factor that you're infusing, and it basically destroys the factor and neutralizes the prostaglandin effect. So this is seen more often in severe forms of hemophilia. It's also more common in hemophilia A as opposed to hemophilia B. You see it at about 25%. Some sources say even 1 out of 3 patients may develop inhibitors at some point. And in hemophilia B, you're only going to see 85% or less of your patients developing inhibitors. So you can quantify how severe inhibitor development is by measuring it, and that's measuring it in the Bethesda units. So a high responder is going to have greater than 5 Bethesda units, and a low responder should have less than 5. When you're a high responder, basically as you infuse the factor, it's being destroyed. It's pretty much useless and very expensive, so you don't want to do that. So there's a lot of things that contribute to the development of inhibitors. I've already said the most important contributor, I think, is disease severity. Because the more severe your disease is, the more often you're going to be exposed to therapy. The more intense your doses are going to be. And it's these kind of things that are coming up and showing correspondence with inhibitor development. So it actually takes about 10 to 20 treatments before you'll normally see inhibitor development. Some other factors that play a role is family history. So if someone in your family with hemophilia also had inhibitors, it's very likely, in fact, you have a 3-fold risk increase that you'll have inhibitors. Being of African ethnicity, that increases your risk by about 2-fold. And then being exposed at a young age, so less than 6 months, is also a very big risk factor. So what do we do once we have inhibitors and we still need to treat our patients for a week? If they're a low responder, you may get away with just giving them an increased dose of their factor. But if they're a high responder, you're going to have to use a bypassing agent or some other mechanism. So we have a few different bypassing agents. You have prothrombin complex concentrate, which is your Betulan and prothrombin. You have activated prothrombin complex concentrate, which is your FIBA. And then you have recombinant factor 7A, which is NOVA7. Your main concern with these 3 medications is thrombosis. So you're trying to create a balancing act here. You don't want them bleeding, but you also don't want them having like an MI or something like that. So you just have to be careful in situations like that. And you actually have more thrombosis with your APCCs and your PCCs as compared to your NOVA7. The reason for that is NOVA7 has a slightly different mechanism of action. It works site-specifically, and I think that's mostly due because it requires tissue factor, and so you're not going to have as much of a systemic effect with that. You could also use immune tolerance therapy instead of a bypassing agent, and that's a really expensive option. I know that bypassing agents are also expensive, but immune tolerance therapy can be about $1 million per patient. It's only about 55 to 70% effective. And for immune tolerance therapy, you're going to give a patient high doses of IVIG or cyclophosphamide or something that's immune depressing, and then you're going to be giving them daily doses of high dose factor. And so you don't have to do that for months, and so as you can imagine, it would be very expensive. Some other things about the chart that I'll point out before I wrap up is that the big chart with on the back of the page, these are all on formulary except for FIBA. And I just went ahead and included FIBA because I think it's really interesting, and the patients that I've seen so far are on FIBA, so it seems like it's something that presents to the hospital kind of often. And FIBA is cool because it stands for factor VIII inhibitor bypassing agent, and I just really like it with drug names to make it easy to remember what they do. And And so you can actually notice that with several of the medications. They'll try and throw in little letters, so like Bedlam BH stands for vapor heated. So the names kind of give you an idea of some of their special nuances. Some other things to point out about the chart on the back. I also included extra content, so the ones that have albumin, like I mentioned earlier. Some of them have heparin, so if you have someone who's at risk for heparin allergies, you don't want to use those in those patients. And then just the different factors that are included in the bypassing products. Also included prices, just so you can get an idea of how expensive these things are. But most of them are at least $1 per unit. And so some of the things that y'all might find more helpful, I've included in the fun facts section. And I don't know if they're actually fun, but I like alliteration, so I went ahead and labeled it back with fun facts. And so first thing, you're probably going to want to encourage your patient to use their home supply. These medications are very expensive to give to them in hospital, so it's better for them that they can go ahead and get those, their home supply and use it here, because that'll save both them and the hospital money. Second, you'd like to notify your buyer if you are going to be trying to keep this product in stock, because we don't have them all here all the time. And then a lot of times these patients are here for a while, so you want to just go ahead and get what you need and have it on hand. Thirdly, factor is going to vary the amount of product available in the vial. So they'll tell you that it's a 500 international unit vial, but really it could be anywhere like 400, it could be 450, it could be over 500. And so it's specific to the vial, and it'll tell you on the vial exactly how much is in there. And so you get an order in, and you have to try and match it as close as you can to what the order from the doctor is. And so as long as it's within a 90 to 120% of variance, it's okay to go ahead and fill that medication without calling the doctor and getting it changed. And that you do that during the verification process. And if you notice after verification you're going to go back and fix the order, you should say order adjustment, no change in clinical intent. Orders that are outside that 90 to 120% variance, that's when you are going to have to call your doctor and get an updated dose. And then last thing, on the labels, it's helpful to write what product strength or the amount of product in the vial, that you used, and then how many vials it took. And sometimes you'll have to use like 1,000 and 500 to get the product strength you're looking for. So just writing that on the label so you know exactly how you came up with your dose is helpful. So these are just some of the things that I came across during my time in HEMONC. So I'll try and answer any questions you have.
Any questions for Kayla?
Yes.
Go ahead. This is tell us about, I know the education component of this is huge. Can you tell us a little bit about how you feel the function of education with these specific patient population can impact the hospital side as well as the ambulatory side?
Sure. So I think one of the problems with education in this situation is a lot of times it's the moms getting educated or the caretaker getting educated, not so much the patient. So as the patient ages, they're not taking care of themselves as much. And if you try and shift your responsibility to them, they may not be as reliable with it. And so I think it's important to make sure that the patient is getting the correct amount of education. That way they're not missing their doses, they're not taking for granted that they need their medicine, and they know how to do it. Because a lot of times, mom is coming in and inserting the needle and getting the apparatus ready, so they don't really even know how to give it to themselves. So I think that's probably the focus point you would want in education, is making sure that the patient is herself is actually capable of giving themselves the medicine and understanding the importance of it.
You said something about gene therapy.
I saw some about gene therapy, and what I saw is they're working on it, but right now studies are halted, I think, because there have been some deaths associated with the studies, and so they're not progressing at this exact moment. That's what I'm saying now. There might be some more updated studies that I missed.
Yeah, UMC is what started.
Okay.
It's adeno-associated virus. It's pediatrics. That's for
Dr. Sullivan.
Okay.
Phase 1A, what he said, which is hopefully should be rolling out. Have you seen an update on it recently?
I have not got anything that has to be.
I met with him this morning. He's waiting on one final piece of information.
Yeah, it's pretty interesting. I don't know if you got into it. The lady who basically created the vector is on campus late August. Talk about it. Really interesting.
I think I heard about that after I decided I was going to do for sharing. Any other questions? Thank you.
Anything else to share? What
MRI was negative. Brain biopsy had no signs of inflammation or malignancy. And finally, a family member had mentioned that she had used K2 or Spice. But like I'll talk about in a little bit, it's kind of hard to kind of diagnose somebody with this since it's not very detectable on regular drug screens. So what is K2 Spice? It is a herbal blend that's laced with chemicals that are sold as incense in stores, but if smoked will have produced similar effects as marijuana. These chemicals are considered synthetic cannabinoids because they differ significantly from marijuana or the tetrahydrocannabinol structure by their structure, lipophilicity, and their activity at receptors. So I also added both structures on the handout of both marijuana and then just one type of synthetic cannabinoid. They were developed by John W. Hoffman. So some of them are considered JWH with a number afterwards, with the original intent to try to just investigate other areas that we could use cannabis for medicinal purposes. However, now it is being abused. The mechanism of action of these, they have higher affinity at the cannabinoid receptors, CB1 and CB2, than THC does. They are actually full agonists at these receptors, whereas THC is partial agonist. And specifically, CB1 is found in the hippocampus, the basal ganglia, and the mesolimbic system of your brain. So that's where it's causing the psychomotor activity or the adverse events that we're seeing mainly with these patients of psychosis and anxiety. The CB2 receptors, I just found that they were located in peripheral tissues, and they may help with immune regulation, but I also found that the synthetic cannabinoids don't bind as highly to CB2 than CB1. Also with blood concentrations, they can be found in blood within 5 minutes of ingestion, which usually patients or people are smoking through inhalation with this medication or this cannabinoid, but they can be detectable for up to 48 hours after ingestion. So the main adverse events that we're seeing with this is anxiety, paranoia, hallucinations, acute psychosis, confusion, up to tachycardia, hypertension, and even vomiting or abdominal pain. The paranoia and anxiety are one of the major, or acute psychosis, one of the major adverse events that are reported in poison centers. And I was talking to Stephanie that works in the ER. She said they saw up to almost 300 cases of this in the ER in the last year. So this can be a major issue that can lead to suicide ideation with some of these patients, especially if they have a mental illness in the past. Other major adverse events also reported were rhabdomyolysis, acute kidney injury, acidosis, myocardial infarction, seizure activity, and sudden death, just like we kind of saw with the patient case. And then withdrawal symptoms have been seen that include anxiety, nervousness, headaches, depression, and irritability. So we kind of get you an idea that this can be abusable if they're having these withdrawal symptoms as well. The evidence out there regarding these agents is purely based on case reports. So I kind of pulled some treatment suggestions from what other physicians have done with these toxicities. So they have used benzodiazepines or haloperidol for your acute psychotic episodes, mainly for sedation, just to help get the cannabinoids out of the system. They've also used antiemetics for nausea, vomiting, hypertension, tachycardia. They could use a non-selective beta blocker. They mentioned alpha-1 adrenergic receptor blockers. That's not as commonly used for hypertension and tachycardia, but beta blockers could be a good option. And rhabdomyolysis, you just want to make sure you're assessing the fluid resuscitation and then their electrolytes. And then seizures, you can use benzodiazepines as an anti-epileptic as well. A few case reports that I saw, they did not put anybody back on maintenance anti-epileptic after they left the ER, just because after they got the cannabinoids out of their system, they did not have a seizure again. So mainly it's just supportive care, what the patient comes in with. And like I said, we can't really detect it on the regular drug screen since it does not have a THC component that is measured by our drug screen. There are a few drug screens out there that will detect specific synthetic cannabinoids. I included this ELISA, or Neogen ELISA drug kit. However, it was only caught about 18 of the 73 compounds that are even out there that they even compiled. They said that they had a 99% specificity and a 75% sensitivity. But again, it's just kind of, there's so many products that are being produced on a daily basis that who knows what your patient's actually going to be on when they come in. So it's kind of difficult to really narrow it down. And as far as regulation, on the package it says not for human consumption, but you know, people abuse that. And the DA has put into motion putting some of these substances in Schedule 1 of the Controlled Substance Act, and there's a Synthetic Drug Abuse Prevention Act out there that is trying to put some of these substances into a Schedule 1 drug category. However, they were kind of the original ones, the JWH compounds, so the more frequent ones and the newer compounds that are coming out are not Schedule 1 just yet. So, yeah, that's all I have for this subject. Is there any questions? Yes?
So I know the JWHs are now, you can't get those anywhere.
Right.
So the new synthetic ones, I assume they have similar affinity to the C1s?
Yeah, if not even more.
Okay.
I think that's what they're that's what they're seeing, is that they're either even more affinity to that CD1 receptor or the same. I think all they're doing is tweaking the original structure just slightly, and it's still just having that full agonist CD1 receptor activity.
But if those are the ones, you can still get those in instant shops and stuff, right?
Yes, I actually Googled like how people can get it, and you can get it off the internet. It can come in as a white powder as well, and they can melt it down into the tobacco using acetone, and it just sounds dangerous. But they use it. If I can Google it, I'm sure anybody else can.
We did this for UFC,
Make sure you don't drink it. Yes.
So how was the patient handled?
She passed away, unfortunately. The seizures never actually got resolved. She was on high doses of pentobarbital, carbital, phenobarbital, Keppra, Depakote, everything.
I'm calling it almost like experimental, because we got to the point where it was just, we were trying anything.
Lidocaine,
I mean, literally anything, and like normal monitoring of drug levels, we went shot way higher than.
Did the cannabinoid versus?
You know, when we were having that endemic here in the earlier part of the
Right.
summer, the mortality rate with this was like 88%.
And that was like
crazy.
bad batch. That's what Stephanie was saying. So that's what's scary is when I tried Googling how to make it, because I was like, how are other people making it?
On UMC,
On UMC, yes. Well, so I don't really know exactly like who's actually producing these compounds. I don't know. It's just crazy.
Heisenberg.
Really? Well, I know in a lot of European countries they have it completely banned to have any kind of synthetic cannabinoid, whatsoever. So they tried. And there's a lot of studies in Germany too where the German investigators actually try it to see what happens. That was interesting. On UMC.
So, do you know like what the
Sorry.
time frame was like? I mean, is this like a few hours?
How long
or-
it lasts?
Yeah, well, like that. Also, like this patient that passed away. Was it like a few hours later? Was it like a week? Like,
It was the patient that, yeah, it
Is
was.
it something where like if the duration of the drug, you know, the duration of action, if you exceed that, do they come down and they're okay, or is it like can it be indefinite? I know it may be different for all the different compounds.
I think it could be different. I know the case reports, they actually reported the seizures went away after about 48 hours after it's supposed to get out of the system. I think it depends on how often you were using it. Are you a frequent abuser? That could have been an issue too, of how long those receptors were being stimulated, and then once you stop, I think that could be a factor too.
Patient specific,
Mhm.
so it could be their first time smoking it and they could die just instantly, or they could get a renal failure rapid and die a week later, or they could seize like this patient for over a month, 3.5 weeks, 4 weeks, and then eventually like there's nothing else off of it, so you have to drop it. But it's really patient specific, there's no way to know how they're going to respond to it or what exactly it is in here, so it's like so dangerous.
Like some of the patients come in the ER and they're out of it crazy, but we let them chill out in bed and give them fluid, they leave and they're fine. And then other ones come in and
Try to pull the bed over.
yeah. Some of them get real bad insurance can.
Not even a legal.
I think part of it too is what else it's laced with.
Right.
And that's something that a lot of people miss. Like, it's not just these compounds. So what it is, like, they buy the chemicals in bulk online and it's sprayed on organic matter. So whatever that organic matter happened to be, you know. And another thing that I wanted to bring up, just from talking to my recovery patients, there's a new thing going around. It's called medical marijuana, where they're spraying spice on cannabis, and it's medical marijuana, and so they don't realize that they're getting spice with it. So that should be fun.
That sounds terrible.
Just some states.
Does anybody else have any questions? Thank you. Today I'm going to talk about caustic ingestions. There's currently a 50-year-old male in the medical ICU who ingested an alkaline-based drain cleaner, or it was reported to be Drano, and he took 2 scoops of Drano and mixed it with 8 ounces of water, and he drank the water, and then he called for help. So the ambulance got there, he vomited en route on the way to the hospital, and then also they suctioned 150 cc's of bright red blood. And then he was intubated at the outside hospital for airway protection. So for an overview of caustic ingestions, there's about greater than 5,000 reported annually. 80% of these are in children due to accidental ingestions. And with adults, most adults who ingest these are used for a suicide attempt. So the severity and the extent of esophageal and gastric damage depends on the compound. So the corrosive properties of the substance, the amount, the concentration, and the form, so whether it's a liquid or a solid, and also the duration of contact with the mucosa. The most common ingestion is strong alkali, which is what this patient ingested. It's usually sodium or potassium hydroxide, and these are also known as lye substances. And these are in drain cleaners, household cleaners, and batteries. Less common would be acidic cleaners, and these are hydrochloric sulfuric acids. These are in toilet bowl cleaners, swimming pool compounds, and then battery fluid. And these are less ingested when I think they burn more, so they have a smaller amount that they can ingest. So the patho, with the alkaline ingestions, you get rapid liquefaction necrosis, and that is just necrosis. You get tissue formation, you get pus and a mass that forms in your esophagus with your tissues. And that leads, and it can extend through the mucosa and then the esophageal wall. And eventually the tissue fluids will alkalize the buffer it. So, and then with these substances, you get extensive transmural damage. So you get esophageal, gastric, and duodenal perforation, mediastinitis, peritonitis, and then some kind of death. The liquid lye, that causes more damage because it can spread and cover more mucosal surfaces. The solid lye is more localized injury to the esophagus. So the liquefactive necrosis, it lasts about 3 to 4 days, and it's associated with vascular thrombosis and mucosal inflammation, and it gets sloppy and ulceration eventually happens. And so then over the next 2 weeks, the esophageal wall, it gets thinner due to the slopping, and then you get developed granulation tissue and fibrosis. And then re-epithelialization of the esophageal wall can take up to 1 to 3 months. Long-term complications, you can get stricture formations. These develop in about 1/3 of patients who do ingest these substances. And it depends on the depth of the damage and the degree of the collagen deposition. And usually these develop around 2 months post-ingestion, but it can occur as early as 2 weeks or even years later. So some pathoclassifications, it's first degree, second degree, or third degree. So the superficial mucosal damage
then focal erythema, edema, and hemorrhage, that's first degree, and also the mucosal swabs, and usually don't get scar formation in these. And with second degree, you get mucosal and submucosal damage, ulcerations, exudates, vesicle formation, and then granulation tissue and fibroblastic reaction producing scars, and that's when you can get your strictures. And then with third degree, you get transmural and deep ulcers, and then black discoloration and perforation of the wall. So to diagnose these, they do an upper GI endoscopy, and that's done within the first 24 hours. And they usually try to do it within the first, it's preferred to do within the first 12 hours. It's not preferred after 48 hours due to the esophagus being thin and you don't want to perforate the esophagus. So there are different grades. You can grade 0 to 3B. So grade 0 would be normal. This does not need any treatment. And then grade 1, mucosal edema and hyperemia. And then 2A, transmucosal blisters, hemorrhages, erosions, and whitish membranes. Grade 1 and 2A, they don't require any therapy either. And you can start a liquid diet 24 to 48 hours and then advance your diet as tolerated. So grade 0 through 2A is excellent prognosis. It's usually not associated with acute morbidity or stricture formation. And then grade 2B and 3A, this is when you get 70 to 100% do develop strictures. Grade 2B is just grade 2A plus additional ulcers. And then 3A, you get small scattered area of ulcers and areas of necrosis. And then 3B, which would be the most severe, is extensive necrosis. And with these last three, you want to do nasoenteric tube feeds after 24 hours. And then steroids are not recommended. They did not, in the studies that were done, steroids were not seen to decrease the rate of, or the incidence of stricture formation. And with 3B, there's a 65% early mortality and need for esophageal resection with colon and jejunum. So as far as management goes, when you call poison control, the main thing that they tell you is to secure the airway. So our patient's airway was secured at an outside hospital. You want to do chest and abdominal films, and that's to look for perforation. So if it's in the mediastinum, then that indicates an esophageal perforation. Or and then if it's lower down, that's more gastric perforation. Supportive care, labs and vitals, you want to look for signs of acidosis, shock, and hypotension, and then treat accordingly, and then make the patient NPO. Gastric acid suppression, so an IV PPI is preferred. This patient went on Protonix twice a day. If surgery is indicated for disc perforation or mediastinitis or peritonitis, and then broad spectrum antibiotics may be needed. You do not want to give emetics because vomiting will re-expose the esophagus and it can cause more damage, and then the acid will just make the damage worse. Neutralizing agents you do not want to use to try to neutralize the substance. That can release heat, adding to injury to the chemical destruction of the tissue. And also nasogastric intubation to remove the agent is not recommended. This can induce, again, vomiting. You might perforate the esophagus. And also when you go to intubate, you do not need to do a blind intubation because you could lead to perforation and then difficulty reintubating. So an update on this patient, his caustic ingestion was graded as a 3A. He had extensive transmural damage and ulcerations. They repeated the EGD 1 week later and he did show improvement. They also inserted a J tube for feeding. And then he had a fever of unknown origin, so he was starting on broad spectrum antibiotics. Any questions?
Okay, Chris? Okay, that's great. Okay, please, that's all our speakers today. We do need to get your evaluation. Be sure to put your name